loss and dementia and talk through practical advice and support to help you deliver the best hearing outcome for patients and their families. So with that, I'll thank you, Jenna, and I'll hand over to you.
Thank you. Hope everyone can hear me all right. I will just share my screen. I've prepared some slides, so hopefully you can all see this okay.
Yeah, we've got that, Jenna. Thank you.
Brilliant. Right, hang on. Sorry, I'll just check I can still see you. Yeah, so thank you very much for the introduction. So as Susie said, I'm Jenna Littlejohn. I work as a research fellow at the Manchester Centre for Audiology and Deafness. I'm a dementia researcher by trade, and I've come into the audiology world about 15 years ago, and have been really interested in understanding the links between hearing loss and dementia, and how really to best manage and support people with hearing loss and dementia from a hearing side of view and from a dementia side of view. So I've been working for many years with different professional groups. So some of that's what I'm going to talk to you about today. So what we're going to cover is how are hearing loss and dementia linked? Do hearing aids protect from dementia? This is the age-old question we always get asked. And how can I best support somebody in clinic with dementia? So there should be some time for questions at the end, but please do, if anybody's got any burning questions or want to ask something as we're going along, please do feel free to, I'm not sure how you normally do it, if you want to speak in the chat, if you want to just speak out, I'm happy with anything. Keep it as, you know, sort of informal but informative as possible. So if anything anybody wants to know, please just do shout out. So before we kind of start with answering these questions, I thought I would talk a little bit about the terminology that we're going to come across today, because this is something that I think often gets really confused when we're talking around cognitive decline, cognitive impairment, dementia. So cognitive decline sounds awful, and people think, oh, I don't want to get cognitive decline, when actually it is a natural process that occurs during aging. So as we age, we would expect people to become a little bit more forgetful. They would have their attention span isn't as good as it once was. You know, your brain doesn't work as fast as it did. And so this is a graph that was a study from a few years ago, and I always show this one because I think it quite nicely shows what happens in normal aging. So these are cognitively healthy people. It looks much more dramatic than it really is, so don't be worried. Our cognitive abilities don't quite slope off quite so linearly, because these are our Z scores. So if we take average scores as 0, we can see that actually people who are under the age of 50 tend to perform a bit better than average, and people over the age of 50 tend to perform a little bit worse, and it declines as we get older. But then there are some things such as world knowledge and vocabulary which remain pretty stable and actually increase as people get older. So this is what we would expect as people age. There's then this other trajectory. So this is the sort of cognitive decline I was talking about with natural normal aging in purple, and then we have this impairment trajectory in green, and we can see that actually they often get confused because they follow the same trajectory over time. So for many years there will be some slight decline where they are the same, and then suddenly there'll be a drop off and a much bigger drop off. And this is the trajectory that we're talking about when we talk about cognitive impairment and dementia. But they do often get confused because it is very, very hard to separate people out in this part here. I don't know if can you see my mouse? I'm twiddling around on the screen. I'm not sure if anyone can actually see what I'm doing. So it's sort of as the graphs come away. So cognitive impairment and dementia then are completely different from a normal cognitive decline. And dementia is you might have heard it as this umbrella term to describe a syndrome. And that's a group of symptoms. So dementia itself isn't a disease. It's not something that happens to everybody. It's a group of symptoms that are used to describe a progressive decline in more than one brain area that affect independent functioning and activities of daily living. So basically, the way I sort of think about it could be, if you think about certain types of cancer, you have one disease. I know can be different, but for the analogy terms, if we think about cancer, it's one disease that affects different parts of the body. So we're going to have different symptoms depending on where the cancer is. With dementia, it's almost the opposite of that. We have various different diseases that affect the same part of the body, the brain, but they affect all slightly different parts of the brain and affect the behaviours in different ways. And they lead to similar symptoms because they're in the same part. But the brain is very fine-tuned, so each different part of the brain has a role. So, you know, this part here might be responsible for memory. We have inhibition and behavior at the front, and depending on the disease which is causing the dementia, the symptoms will be affected differently. So the most common disease that causes dementia is Alzheimer's disease. I'm sure everybody's heard of this, and Alzheimer's disease affects up to 80% of all dementia cases, and that is associated with memory loss, which is why I think people often think about cognitive decline and dementia as being memory loss. They're not necessarily, but one of the earliest and most prominent features of Alzheimer's disease is this short-term memory loss. And also in the normal cognitive aging, people's memory does get a little bit worse. You do get a bit more forgetful. So this is why the kind of cognitive decline, cognitive impairment is often thought of with memory. But if I go back to here, actually lots and lots of different behaviours that our brain does are also involved. So we can come back to this if anything's not clear. So current UK statistics from Alzheimer's Research UK suggest that 1 in 14 people over the age of 65 currently have dementia in the UK. It disproportionately affects males and females. So 65% of those are females, and this number is on the rise. So we have dramatic population aging going on. So this is it's quite small. I'm not sure how big you can see it, but we're about here with this dot. So there is just under 1 million people currently in the UK living with dementia. We see by 2030 it's likely to be over 1 million, and then we'll exceed to over 1.5 million by 2050. So really, in a relatively short space of time, we're almost doubling the amount of people living with dementia. So if you think about the population of clients that you're likely to see, you're going to be seeing more and more people on this trajectory. If you think back to that green line on the graph, you're going to see people somewhere along that trajectory journey, if you're seeing people over the age of 65 for certain. And according to Dementia UK, every 3 minutes somebody in the UK develops a form of dementia. So it's really, really prevalent. So we'll kick off with the first bit then. Hearing loss and dementia, how are they linked? So I'm sure people have come across this graph before. This is what's been shown for many years, where hearing loss was linked as one of the potentially modifiable risk factors for dementia. So the line is your life trajectory, and you can see that hearing loss at midlife is associated with increased risk of dementia. This increased risk of dementia is depending on the severity of hearing loss. So various different studies have shown that if you have a mild hearing loss, you're twice as likely to develop dementia, and if it's severe, you're up to 5 times as likely to develop dementia as somebody with normal hearing. The trajectory of cognitive impairment is accelerated for people with hearing loss, which means that actually, if you are on this pathological decline, then you will decline quicker if you have hearing loss than somebody who who has normal hearing. And so because of this, hearing loss has been included as a potentially modifiable risk factor. But we do need to caveat potentially modifiable risk factor, because we're still not sure whether by modifying the risk, we will be able to, but by modifying the risk, in this case, by modifying hearing loss, we will eliminate this association. Because if you see up in the top here, it says this is the percentage reduction if this risk is eliminated. So by treating hearing loss with hearing aids, we don't necessarily eliminate the risk. You'll know from working with your patients, we're not treating the hearing loss, we're treating the symptoms. So it's really important to kind of caveat, and this is something that I'm happy to discuss a little bit after, when people talk about, oh, if I get hearing aids, will that stop me getting dementia? You know, we really don't have the evidence to support that at this stage. So it appears that hearing loss is a risk factor, but we still don't really know, based on the evidence that we have, is it hearing loss that comes first, and it's that's affecting cognitive function? Is it cognitive function or impending dementia which affects people's hearing, or is it a common factor which could be affecting both of them? So I'll just very quickly do a kind of whistle-stop tour of how this could be. So how could hearing loss lead to dementia? So one of the theories is that hearing loss increases listening effort, and therefore it leaves fewer cognitive resources available for other tasks, so potentially at the detriment of being able to take the information in and form memories. However, the links between hearing loss and dementia still remain, even when cognition is tested with visually based tasks. So even when we are not using our auditory domain at all, people with hearing loss still have performed worse on cognitive tasks, suggesting that it's not an artifact of the fact that people just aren't hearing as well. It could be then that actually over time, this increased listening effort and this increased cognitive demand has a permanent adverse impact on our cognitive function. But again, that's kind of unlikely because cognitively taxing things are often linked to preserve cognition. We've all heard use it or lose it, you know, keep your brain active, keep stimulated. So it's unlikely then that actually increasing effort in our brain is going to lead to a cognitive impairment. And it could also be that hearing loss could impact indirectly through what we call the psychosocial pathway. People with untreated hearing loss might become socially isolated or depressed, and these themselves can also lead to reduced cognitive performance and increased dementia risk. So could it be a few of these things working in combination? How about the other way around then? Could dementia or reduced cognitive function affect somebody's hearing or listening abilities? So it could be that somebody may appear to have poor hearing when actually their listening difficulties are due to their cognitive impairment. So they've got disease in their brain, potentially in the auditory areas, not necessarily the cochlea, but higher up in the auditory processing areas, which means that the brain can't respond to sounds as quickly. And this is something that I think is really important to keep in, because hearing loss and how we measure hearing is cognitively taxing. We use our cognitive function to be able to undertake behavioural measures of auditory function. We use our cognitive function really to do everything. So to separate out hearing from cognition completely is really, really hard to do. And one way to avoid this kind of confounding could be using objective physiological tests of hearing function. But we all know that they're not as easily available in a clinical situation and potentially not really suitable for people living with dementia. So we, you know, might not be able to sit still enough, might not be able to get good responses from those either. So hearing loss, could it be then that there is something else causing both of them? Hearing loss and dementia are complex multifactorial conditions. They're not necessarily caused by one certain thing. So why are we suggesting that hearing loss would lead directly to dementia? They do share biological causes, these neurodegenerative factors, and they also share many of the same environmental and lifestyle risks. So it could be that over time, many of these different things in combination could lead to this increased risk and this increased association that we see between them. I think what's really important, and which often gets sort of sidetracked when people are looking to hearing loss to reduce that risk of dementia, is that hearing loss in dementia actually represents an unmet need. So people with dementia plus sensory impairments, compared to people with dementia without any sensory loss, have decreased rates of orientation, so knowing where they are in time and space, self-location, using visual and auditory cues. They have decreased rates of social activities and hobbies and community interactions. and increased risks of hallucinations, delusions, depression and aggression, increased caregiver burnout, and increased rates of distress. So we can see that these all lead to an overall negative impact on mental health and cognitive well-being, and they can actually exacerbate the dementia functions if we have untreated sensory loss. And it often remains unrecognised. So this was a study in Manchester done over 20 years ago now, but actually the numbers are still the same. We expect it to be exactly the same. We don't think anything's changed at all. This was done with a group of people living with dementia in the community. They had hearing assessment that they'd previously not had, and 80% had a hearing impairment, which was previously undiagnosed. So in lots of cases, there might be some overlapping symptoms of hearing loss and dementia, subtle forgetfulness, withdrawing from conversations, repeating, and this is misattributed by care providers or the person themselves to all being part of the dementia syndrome, and nobody's really looking at hearing loss as a possible cause for any of these symptoms. So, do hearing aids protect us from dementia? So I've sort of touched upon this, looking at the links before. We currently don't have any evidence to suggest that they do, to support this. And I'll show you a little bit of the evidence that we do have. So there was a recent study which was published last year, a review, which looked at the role of what hearing aids do to cognitive function in terms of cognitive decline over time, or cognitive change. So over a minimum of 3 years, we look at these were studies then that have investigated hearing interventions in the form of hearing aids, and they've looked at whether somebody has developed cognitive impairment or dementia, or whether they have measured decline in cognitive performance in people who are normal cognitive function. And what we could see for incidence, so these are new cases of cognitive impairment and dementia who've developed. 4 studies reported that they were lower among hearing aid users versus non-hearing aid users, to sort of suggest that hearing aid use is protective. But then there are 5 studies that reported there was no difference between people who wore hearing aids and those who didn't. And when we just look at decline over time, so actually looking at how much worse people get over the 3-year period, 4 studies reported that there was reduced decline among hearing aid users versus non-users, and 3 studies reported no differences. So it's a really, really mixed bag. And it's important to note with these ones, in the studies that did look at, that did report a difference, that we often have this demographic confound of elite group of hearing aid users. People who use hearing aids in these studies tend to also look after their general health better. They tend to be from different backgrounds, different socioeconomic status, different financial implications. So it could be that there are this elite group of hearing aid users, and it's not necessarily the hearing aids themselves, it's something else, the confounding confounding factors. And so really, to be able to answer this question, we need some prospective trials. So I'll come back to that in a second. There was another paper which was all over the news towards the end of last year, which was UK Biobank data. So it's a large data set with thousands and thousands of people, and they reported a 42% increased risk of dementia in people who self-reported hearing loss in this sample. And the authors said that the hearing aids, people who wore hearing aids, had the same risk as those who had normal hearing. However, and you see I've highlighted in yellow here, this paper was subsequently retracted. So this was all over the news saying, wear your hearing aids, it reduces your risk, if the increased risk that we see with hearing loss. However, towards the end of the last year, this paper was actually retracted. This was published in Lancet, one of the big Lancet public health papers. And it was actually retracted because they'd actually got the data the wrong way around. They coded hearing loss with hearing aids and hearing loss without hearing aids. They were switched. So what this actually showed was there is an increased risk of dementia in those who wear hearing aids compared to those with hearing loss who don't wear hearing aids. So we think, oh my gosh, nobody imagines this is the case, and it's not really the case. But it's just a caveat that this is what happens a lot of the time when we see these associations, is that actually hearing aids probably haven't had any effect in this study. This is self-reported hearing aid use, self-reported hearing loss. But we probably would expect increased risk in those who wear hearing aids. And you think, why would we expect hearing aids to increase the risk? Well, in a sample like this, hearing aid use is a marker of at least moderate hearing loss, and hearing loss is associated with dementia. So I can't see because I'm just looking at my slides. I can't actually see anybody, but I hope this makes sense. So what we're not suggesting that the use of hearing aids actually increases the risk, but what we're suggesting is that really this is telling us what we know from this 42% increase and what we know from other literature. The worse your hearing is, the more likely you are to wear hearing aids. The worse your hearing is, the more likely you are to get dementia. So really this is kind of reiterating this hearing loss and dementia link, but the role of hearing aids is really, really confused. So there has been a recent prospective hearing aid trial. They're really hard to do in this country for various ethical and financial reasons. We wouldn't be able to do them, but there has one that's just come out of America, which was published at the end of last year, which is the ACHIEVE study, which people might have come across. This was almost 1,000 adults aged between 70 to 85, and they had a previously untreated hearing loss, and they were randomized to a hearing intervention or a control condition. And the outcome was a 3-year change in global cognition. Now, this was actually a really, really good study, a really good hearing intervention. They had audiologic counselling, provision of hearing aids, assisted listening devices, and really good follow-up and adherence to using their hearing interventions. They were really trying to get the best out of people using their hearing. And there was also a control condition, which was just general health education and chronic disease prevention. And what they saw was that there was no difference in global cognition between the groups after the 3 years. And 3 years essentially isn't long enough to see a decline in people who were previously cognitively healthy. So they do need to be followed up for longer. But there was a secondary analysis which showed there was a slight positive effect of hearing aids on cognitive decline in a subgroup of people who were at higher risk for developing cognitive impairment. And this is a bit confusing because it's probably the opposite of what I would have expected to see. So this is suggesting people who are at higher risk of developing dementia for other risk factors, so diabetes or poor health, low socioeconomic status, poor education. And we saw that in this group of people, there was a slight positive effect. This was reported, and this is now being sort of held onto by the group. But it's not clear why hearing aids would have a more protective role in this group of people. I would probably have suspected it would have been in the other group of people. So this is it's a bit of a spurious finding, I would say, and actually something that's not the study hasn't been powered to look at this analysis, but something that the researchers are going to investigate more and hopefully have some answers for in the future. But yeah, sorry.
Could I ask a quick question on that topic? Because the people that were at risk, of course, the hearing loss was involved, but other medical conditions may be a contributor as well. Were they under treatment for the other conditions that may have showed that their cognitive decline improved? Was it? I mean, you can't put it down to just hearing aids alone, can you?
No. So I think this is why it's a bit of a spurious. So these people basically they grouped. There was two. They recruited from two different groups. So they put everybody together in the study, but they recruited from a general kind of what they call a typical general population, and then they recruited for another. I can't remember what the other study was, but it was basically another risk factors, and it was a high risk. It was like atherosclerosis group. So is your question is, are they being treated for the other risks factors?
Yes, because that could have a positive impact on that cognitive decline
exactly
being reduced.
and not the hearing aids.
hearing
And
aid.
this is what we were. And do you know what? Off the top of my head, I can't remember whether they've even reported anything to do with treatments in that group. But I imagine they would be.
Yeah.
They would, they would have management for diabetes. How well they're controlled and things. But these people would.
Ask something. What about
Sorry?
the social interaction of these people? I mean, if they're not mixing with people on their own, maybe day to day, not actually having a conversation with other people, they're going to decline probably much faster than somebody who is much more sociable and interacting with people on a daily basis, surely.
Yes, yeah. So I think this study tried to randomize people, so tried to match them as closely as possible for all these different factors. So they were put into a hearing intervention or a control condition, but they were tried to be matched on all these other factors that we know would have an impact on, dementia risk. And which is why these studies are so hard to do, because we can't control for everything. And even if you think we're controlling for them, there is still some what we call residual confounding, which we won't be able to control for. Some people might be, everybody's risk will be completely different. And maybe what they are suggesting is, or maybe that's something that they were hoping to see potentially with the hearing intervention. Are these people then socializing more? And could this be the reason? That we're not projecting on what the reason is as to whether we think that's definitely going to make a difference. What they try to look at is matching people as closely as possible for all these other factors. And when we can take into account these things, do we see an impact of hearing aids on their own controlling for these things? And they didn't. So you're right, all these other things come into play, and it's such an individual basis. So I think that's the issue with these studies, and that's the issue with when we talk about this hearing and dementia risk. We tend to see that there's this increased risk, and they're from really, really great big studies with lots and lots of people. And in some cases, the risk is appears to be quite big, but that's because they've kind of statistically controlled for lots of measures, and on an individual level, we can't actually comment on what the risk is. So if that makes sense.
Yeah.
So on an individual level, we can't see. So I don't know if people have heard this 8%. This is batted around all the time. Hearing loss increases your risk of dementia by 8%. That came from the Lancet publication, because it suggested that there was this 8% increased risk of dementia cases. But that's actually kind of reported wrong, and it's been put out into the media slightly wrong, and people have kind of not understood, which I wouldn't expect anyone to, because I don't even really understand it, and I'm supposed to be trying to keep up with stats and things. But this is a population attributable fraction, and basically it's because hearing loss is so common in the population. So what it's basically saying is, if we can completely remove hearing loss from the population, then we could reduce cases of dementia by 8%. Treating hearing loss or giving people to socialize more with their hearing loss isn't going to affect that at all. We're talking about completely removing cases, and that's because hearing loss is so prevalent. So if you went to and that data is based on UK data. The studies are from the UK. If we went to another country, the risk profile might be slightly different, because hearing loss might not be as common. We look at the different risks. As this a study we're doing at the moment actually is looking at the global impact of hearing loss on dementia, and what we're trying to look at is this 8% statistic that people keep talking about, is this actually only suitable for the UK? And actually, what is the worldwide message of hearing loss and dementia? So I've gone slightly off topic there, but I hope we sort of understood that this is trying to look at hearing aids, but we can't control for every single thing that could potentially affect it.
Thanks, Jenna. That's useful.
Right. Sorry, let me get back onto my screen. But I I think we're missing a trick if we are just looking at hearing loss and from a cognitive, so it's sort of hearing loss in the dementia field from a cognitive decline point of view and scores on a cognitive test. And really, as we've suggested, hearing loss is an unmet need for people living with dementia. And there is evidence that we can really improve people's quality of life and benefit on their functional impairments by managing somebody's hearing. So I think for somebody living with dementia, it's not really important if they, score 1 point worse on a test the next year. What's really important is how they're functioning in their day-to-day life and how they're getting on. So there was a big European study which has come to an end now, but this was doing a randomized controlled trial looking at just that, looking at hearing intervention, and it was sponsored by Starkey for hearing aid, the hearing aids given to the study. And these were people living with dementia in the community, and they were randomized again. So we're trying to get this kind of best measure of really looking at of keeping everything else the same and really looking at what we can do by giving somebody a really good sensory intervention. Which was full hearing and vision assessment, glasses and hearing aids, adherence support over 12 weeks. And the sensory therapist really tried to work with care partners to support their sensory environment, communication training. They worked with the person with dementia and their care partner to understand what their goals were around what do they want to get best out of their functional abilities, what do they want their hearing to be able to give them, and they really worked with them. So this is being written up for publication at the moment, but preliminary evidence from the field trial really showed that this sensory intervention and really good support and management of hearing loss improved people's qualitative quality of life, improve their functional ability, their communication, decrease their social isolation, and decrease their dependence on their care partner. And some quotes that came from the care partners is that it's clearly benefiting. The person with dementias talks about the impact that the hearing aids have made, or it took a lot of persuasion and encouragement to wear them, but the person with dementia is growing in confidence and independence. So really suggesting that people with dementia can use hearing interventions and they can get some really good benefit from them. And so looking at hearing loss as a risk and using hearing aids only to reduce our risk of developing dementia or to slow it down, I think really is not the only thing we should be focusing on. So that leads us quite nicely to then, how do I support somebody in clinic with dementia? So my phone's ringing from nursery, it's distracting me. How do I support somebody in clinic with dementia? So a couple of years ago, we wrote a paper. We really wanted to try and answer this, and we looked at aiming a document at hearing care professionals to increase the quality of care people give with dementia. This is a question that I got asked and members of our team got asked a lot is, but what do we actually do in clinic? We're seeing more people with dementia. We're seeing that there's this increased risk. We're going to be seeing lots of our patients are going to be on this cognitive impairment trajectory. What do we need to do differently? So what we aimed to do was to write this version by multidisciplinary professionals. So we needed to get input from people who worked across hearing and dementia fields, who were dementia professionals, who were clinical professionals, audiology professionals, who were occupational therapists, and really try and be able to give some good evidence to the hearing care profession of how to best support their clients. So this paper is freely available, and if anybody's interested in reading a bit more detail about any of these different areas, it's split up into kind of basically an introduction and everything, a whistle-stop tour for the hearing care profession. I can send that around to Susie and the team to share if anybody is interested, or you can access it freely available. It is published open access, so I think you can access it. Everybody can access it. So we start off by trying to really stress the importance of getting away from this biomedical kind of, somebody's got dementia, what is it I should be doing? Right, they've got dementia, I need to do this, this, and this. This is what we change. We completely do different things. It really does need to be a person-centered perspective. And I think actually the hearing care profession do this really, really well in when you're seeing your clients anyway. But it's kind of, if you go back to some of my earlier slides, remembering that dementia is caused by lots of different diseases, and where depending on the different disease, it will affect their brain slightly differently. So if we were to say, right, with everybody with dementia, we just select these 2 frequencies and we just do this, we see them at 2 p.m. in the afternoon, and we, to say you have a set parameter potentially isn't the best thing. We should really concern ourselves with the person you have in front of you, rather than the fact that they have any cognitive impairment or dementia, and adapt the processes for what that person needs, because it will be different to what the next person you see with dementia needs, even if they, for example, both have Alzheimer's disease. So we use this VIPS model, valuing the person with dementia, seeing their individuality, looking at the world from their perspective, and understanding their social environment. And if you apply this into every and it's kind of then kind of pick this up and apply it to every different aspect of the time you might see somebody. So when you're thinking about setting the appointments, you're thinking about setting up your clinic and inviting somebody in, you look at this, you're thinking about the assessment and the intervention. It will really kind of help get the most out of the appointment for you and for the person. And it kind of all makes sense a little bit now, as I kind of keep that in mind as we think about how we adapt the clinical setting for people. So the first thing is in VIPS is the social environment. So we need to have a supportive social environment. And if people are a bit worried about seeing people with cognitive impairment or dementia, it might be because you think you know somebody with dementia and actually they're at a very late stage in their life, or you know somebody and they get on very well. Well, this trajectory is progressive, people get worse, and it's very fluctuating, it's different. So it's really important to have a little bit of dementia training to understand kind of the breadth of dementia and the likelihood you like to see. So there are various different dementia trainings available, all different tiers you could do. But there is a very good start to Dementia Friends. If people aren't Dementia Friends already, you can sign up to the Alzheimer's Society website. I think you can do a 1-hour webinar, and it just gives a little bit of an insight into understanding a bit more about dementia. And there's various different things to think about if you are thinking about potentially setting up a clinic or offering services, sort of expertise for people with cognitive impairment and dementia around understanding capacity to consent, duty of care and safeguarding, and the role of cognitive screening. Now, I haven't really got time to cover any of that, but if anybody's interested, we can talk about that in a little bit. The physical environment is really important for people with dementia, because if you remember, they will have the way their brain processes things isn't quite the same. So if you're thinking in a clinical setting, really reducing any obvious risks, I think we need to do that anyway. Reduce overstimulation is really, really important. So sometimes in a kind of a busy waiting area or noisy, there's noise from different machinery, there's intercoms going off, there's radios or TVs on, there's telephones, there's people talking. This can be really overstimulating, as well as potentially lots of leaflets and flyers and things to make the spaces full of information can actually be too much stimulation for somebody with dementia. And saying that a kind of a less a familiar, less clinical feeling can put somebody at ease a bit more, providing quiet areas away from others, and supporting engagement and wayfinding. So there's lots of things about making your practice sort of dementia friendly, and it kind of basically is these things, looking at less clinical, but also colours. So there's contrasting. People can have visual problems. So there are, you know, are lots of things to consider, but there's lots and lots of information out there. And we do touch upon this in more detail in this paper as well. Even when it comes to things such as making appointments, it's really important to consider the time of day for that person. If you know, people with dementia, sometimes their circadian rhythms, so their kind of sense of night and day, can be all over the place, and they can sort of have a shifting circadian rhythm pattern. So for that person, some people might function much better in the morning, some people might not get out of bed till 3 p.m. in the afternoon. So it's really important to not have a dementia clinic, for example, on a Friday afternoon every week, but potentially consider slotting somebody in when it would suit them best. Give more time if possible, although caveating this with, you know, spending 5 hours for somebody is going to be far too much to do for everybody involved. So consider splitting into more shorter appointments, and even things such as appointment letters. It can really help to make somebody kind of feel at ease, and you will get the best out of the assessment when you meet somebody if they have a little bit of information ahead of time. So when the assessment will take place, where it will take place, who it will be with, if there's any pictures that you're happy to share, this is what we'll do, and this is what we're hoping to do. And then potentially, if they have this information before they come to the appointment, they can either, depending on kind of where they are in their dementia journey, if you like, they might be able to manage this themselves, and it will just give them another prompt, or a care partner will be able to discuss in more detail. This is what you're going to do. This is what we're going to be looking at. Somebody's going to be looking in your ears. We're going to have a bit of a chat, and then we're going to try and do some testing. And you know, you have to put some headphones on, and they can try and ease the person into it before they come into the appointment. Now, there's very limited evidence in the literature of how we can actually adapt the audiology assessment for people living with dementia. And again, it's quite hard for, this is what clinicians are, you know, there's lots of anecdotal, this is what I do in clinic. And so we are gathering this at the moment and trying to get a best practice, and trying to write some professional guidance for, you know, how we, you know, or some top tips for how to tackle audiometry, for example. Because it's important to understand that the persons with dementia, their level of functioning will fluctuate over time. So it might be different from one day to the next, but it is progressive. So it means that every time you see them, they might get a little bit worse, or actually they might be having a slightly better day. So you might get a bit more than you did last time out of them. We could try a different, you know, we'll try it in a different room. We'll try it at a different time of day, see what we can get. So from the literature, in people with mild dementia or mild cognitive impairment, we've seen that audiometry has comparable reliability, but depending on the severity of dementia and as dementia progresses, there's some studies have suggested that about 60% of people with dementia could complete at least some pure tone audiometry. And then another study has shown that actually with no adaptations at all, so if you're going kind of by the book, which I know not people wouldn't necessarily do this in clinic, if you are working with people with cognitive impairment who, you know, you can see as you're talking to them that they're not taking it in, but 37% would complete no part of the assessment. So it's really showing that we do need to adapt our processes. And so what we have suggested is be prepared ahead of time if you can be. So this is why this kind of appointments letter and setup is really important. Do they have any previous hearing data from you or from anybody else? Have they been, you know, have they had a hearing test ever in the past, and what did it look like? What did they see ahead of time? And then potentially you could try and get set up for what is it that you want to get out of the first appointment when you see them. Keep a family member in view can really help to settle the person and make sure that they feel comfortable with everything you're doing. demonstrate the tests, make sure they understand the instructions. It's very easy for people to sort of smile or nod and you think that they understand what's going on and then them just not to respond. And indexing functional hearing. So what, I'm not sure if people do this routinely as part of their practice, but just even understanding the simple questions: what can you hear, what can't you hear, what are you struggling with, what are their goals and communication needs, and what benefits are you hoping to get from any interventions? I mean, are these realistic? That's something else to think about. And therefore, from this information, right, what do I need to be able to, the minimum information I need to be able to potentially offer some hearing interventions for these people. So we've suggested slowing the pace of the assessment. If you're not getting anything out of pure tones, using pulse tones, which help aid alertness. If people won't tolerate headphones or keep pulling them off, don't want to put them on, potentially using sound field or warbles, reduce their test duration, frequent reminders and encouragement, potentially don't use a booth. If you do, take any behavioural response, they might not be able to respond with the buzzer, and consider electrophysiological tests. I know this isn't always feasible to do, but this is something that we are looking at validating in people with mild or moderate dementia, the ASSR thresholds, as these are potentially the hopefully the software is becoming a bit more readily available and a bit easier to get from this group of people. So this is what we're hoping to do over the next couple of years, is to have data to answer that question. And then in terms of interventions, the focus should be personalised and about optimising communication, as we do. And I think with all cases of hearing aids, I'm sure there are some, we need to be sure that we're setting realistic expectations, but particularly in this group of people, if a care partner is coming in and they're thinking, well, I know hearing loss is linked to dementia, if I get hearing aids, it's going to really help them with their dementia, the dementia isn't going to progress as much, they are going to suddenly be able to hear what I'm saying, they're not just going to be sitting there in their chair. I think it's really important for you to have the confidence to suggest, to offer realistic expectations that they can get from their hearing aids. In this situation, they might not be able to help at all. We might just have to try them. I'm not sure if that's something that's available, just offering a trial. Can they manage the hearing aid that you've selected for them? And which features do they need, and all those things. In some cases, personal amplification devices might be easier to manage, and it's really helpful to talk to the care partners about strategies for communication, bearing in mind their hearing and their dementia. And this is something that, from working with clinicians across the field, across the hearing and dementia professions, it has come up a lot. So a very quick introduction to a piece of a flyer or a little booklet which I've created, which is freely available to use. And if anybody would like to have a copy of this, I have some glossy copies, but they are very quickly dwindling. But this is available as a print ready PDF, so I can send across to everybody if anybody's interested. And it's just a booklet to give to your patients, or to be able to offer people if you need a bit more information about understanding hearing and sight problems and their links to dementia. So I've just put it through as the print copy to show you. So this is the front cover. Talk a little bit about how are hearing and sight problems linked to dementia, the overlapping symptoms in the early stages, why it's really important to consider hearing and sight loss for people who are living with dementia, a little bit about how much it's harder for somebody if they have dementia and sensory loss. They have to work even harder. It's this double hit, so it's really important we do manage it. And then how can I support somebody with hearing and sight problems? So you can support them by bringing them regular hearing and sight checks, inform your professionals, adapt the environment, things they can do at home, make the most out of their remaining hearing and sight. And this is where hopefully they'll come in and help you. They may need extra support and adherence. And we've got some quotes there from people who are carers of people who had had hearing loss and dementia, and then some top tips for successful communication. So if anybody would like that, I know some clinics use that a lot, and so I'm happy to share that with you, and you can freely distribute it if that would be helpful. So I will stop talking in a second, but just to kind of summarise a whistle-stop tour, how are hearing loss and dementia linked? They are linked. We know there's this increased risk of dementia for people who live with hearing loss, and there appears that for people who live with dementia, they are more likely to also have hearing loss, which is untreated. But we're still unsure of the mechanism of how they're linked. Do hearing aids protect from dementia? We currently don't have any evidence to support this, but we do know that they can be really beneficial in helping improve people's quality of life. And how do I support somebody in clinic with dementia? So we suggest using this VIPS approach, looking at goal setting. What do they want to get out of their hearing? Is it realistic actually that a hearing aid is going to help them, or can we help them by offering some, wax management is really important, and which again I haven't had a chance to cover today, but looking at how we can basically get the best out of their hearing. Is it just simple assistive listening devices to help them watch the telly, to help them to go out and socialise, to help them on the telephone, and how we can slightly adapt procedures. So there's more information on that in this paper. Again, I can send round if that would be helpful to anybody. So we have a few minutes for questions if anybody's got time or has anything they wanted to ask. I just thank you very much for attending, for Starkey for inviting me, and for the funders of the work to say. So I will stop sharing this now and come back to you. So if anybody does have anything they'd like to ask or potentially pop in the chat, please feel free. Thing wasn't clear.
Gianna, you mentioned about screening for dementia or cognitive issues, and I know there's some various tests you can use. Is there any words of wisdom you want to give to anyone in the room that might be a little bit worried about even approaching the subject with a patient?
My honest opinion is, why are you doing it? Why are you doing cognitive screening? So are you doing it because it's going to inform your practice? I know if somebody scores something on a test, then I'm going to offer this hearing aid, or I'm going to adapt my process this way. If you don't know what you're going to get with the information, I would stay well aware. That is my honest opinion. I think you have enough going on, and I do think it's slightly out of a scope of practice. And I know lots of places are saying we should, we should be picking up potentially people with cognitive impairment. We have a duty to do it if they're at increased risk. In the UK, there's no national dementia screening programme, so there's no reason why audiologists should suddenly do that if GPs don't do it. But also, things like hearing loss can affect cognitive screens. So if somebody has unmanaged hearing loss, we would expect them to perform worse on the test as an artifact of not hearing the questions. So I would caveat that with I would stay well away from doing cognitive screening.
Okay,
unless
that's great.
But happy to discuss if anybody really wants to do it. I just think it opens a whole different minefield for things, and like you said, if people then sort of say, oh, we're going to do a cognitive screen today, and someone says, well, I've come in to have my hearing checked.
Yeah, I know it's a difficult subject, but I sometimes get asked the question, and I think the intention isn't to do anything to treat it, but to then refer further on to the GP.
Yeah.
But if you're in any way suspicious that that's some of the risk to the hearing loss, I would probably just refer anyway.
Exactly. I think that's the thing. I think potentially, if the person's worried themselves, or if you pick up something and say, I'm not sure how much of this is hearing, or actually there's some tests, I'd refer back to a GP who might be better placed or have more time to investigate the cognitive difficulties, because it's a big thing to say to somebody potentially you've just met. I don't think your brain's working very well.
Yeah. Thank you.
Thanks, Jenna. Any other questions for Jenna before we close out?
Oh, thank you, Jenna. It's very interesting. Thank you.
Okay.
Yes, thank you, Jenna.
Thank you. Welcome.
Great. I think you've done an amazing job, Jen. I think you've answered most people's questions as you've gone through, and just really interesting for you to walk us through that research, because obviously it's quite layered. So really helpful for you just to unpick that and kind of talk through it. So thank you, and also for the practical solutions as well. So I can liaise with you on that booklet, and if anybody wants a copy of that, then just get in touch with us and we can share that with you. Otherwise, just a huge thank you, I'm sure on behalf of everybody on the call, for joining us today and for sharing your expertise on this really, really important subject. And thank you to everybody. Have a lovely rest of the afternoon, and we'll catch up with you again very soon.
Thank you.
Thank you, Jenna.
Thank
Thank
you,
you,
Thanks,
everyone.
everyone.
Thank you.
Bye.
Bye-bye.